the idea of functional versus non-functional neuroendocrine tumors comes up a lot in the clinic, and really the essence of what we call a functional tumor relates to whether or not some of the hormones or peptides that are secreted by a tumor may result in specific symptoms. When substances such as serotonin that are secreted by tumors from the small intestine or the midgut are secreted in sufficient amounts, that can lead to patients having diarrhea or flushing symptoms. A syndrome. It's a collection of symptoms that results in specific symptoms that can be identified by the physician with the patient when they ask the right questions. The functional tumors that result in specific symptoms that are collected in a group of symptoms leading to a syndrome. The most classical one is carcinoid syndrome, as I mentioned, with classical flushing, diarrhea, and sometimes wheezing or bronchospasm. That's the carcinoid syndrome that we see most frequently. There are other ones. For example, the secretion of a substance called gastrin can lead to high levels of acid in the tummy, and this can result in peptic ulceration or ulcers of the duodenum or the stomach, and diarrhea from a massive amount of acid that's been secreted, and that's called the Zollinger-Ellison syndrome. It's less frequent, but we do see it, especially in the NET centers that are dealing with gastrointestinal disorders as well. Some of the other ones then would also be the secretion of tumors from the pancreas of insulin, and if we secrete even small amounts of insulin from benign tumors, they don't have to be malignant at all, this can result in symptoms of we call hyperinsulinism, with hypoglycemic episodes, feeling of tiredness or weakness or malaise, especially in the prolonged fasting period, or even some palpitations or feeling of sweaty palms, etc. And they're the classical symptoms of what we call hyperinsulinism, or too much insulin secretion. There are indeed other rarer functional tumors, some from the pancreas, some from the intestinal tract, that result in specific syndromes such as VIP, hypersecretion of a peptide that's released in the small intestine that causes diarrhea, and it can be very debilitating, or indeed a hormone called glucagon, that if that's secreted in excess, it can lead to a rash, and it can also lead to diabetes mellitus as well. So there are rarer ones as well. It's not always inherent that if you've got a lot of symptoms from a functional tumor that you will do less well than somebody what we call a silent type tumor. Functional versus non-functional tumors have largely different prognosis. There are many factors that come into that. When we talk to patients about getting the tumor stage, it usually refers to looking at the primary tumor, looking at the tumor of origin, and working out if the tumor has spread any further. And the way the tumors spread are either by local extension, and I would give you an example, that is tumor of the stomach wall, for example, of the gastric wall, could go to invade the pancreas, or it could invade the anterior wall or the posterior wall of the liver, for example. So the tumor can grow out to involve adjacent organs. So that would be a local, or indeed local vascular structures, such as the celiac artery or some of the big vessels that are important. It is important to know that because surgical resection may not be possible if you've got what we call locally advanced spread. So if the tumor is involving a big artery that we can't do without, you may not be able to resect that. The second way, that's a local spread, the second way that they can spread is through the lymphatics. And these are small lymph channels that we don't always see on CT scan or on other methods, where the tumor, the primary tumor, will spread some small amounts of cells, we call those micrometastases, along very, very narrow and thin lymphatic channels to local regional lymph nodes. So close to where the tumor are, and sometimes this lymphatic spread can go to lymph nodes that are a long way from the tumor. And the example that I would give, again, if we took a neuroendocrine tumor involving the stomach, it could spread, for example, to lymph glands in the neck. And that would be more important in making a decision in regards to therapy than a small lymph node very close to the primary tumor itself. And finally, there are metastases that can go through the blood vessels that will go usually to the liver, or perhaps sometimes to the bone, or other distant sites that are rarer. We call those rare metastases. But the liver would be a frequent one, and that's why, in terms of staging a tumor, we need to know what it looks like locally, how big it is, has it gone outside of the primary organ site, are there any lymph nodes locally or a little bit further away, and indeed we always look very carefully at the liver to see whether or not there's been liver spread, because of course, depending on the stage, if it's more advanced or less advanced, we're going to adapt our therapeutic program with respect to that. And it's also important to say that there are, in some cases, a prognostic relevance whether or not different sites are involved. Some patients with bony metastasis, for example, will not do so well, but some patients with bony metastasis can do well for some time as well. So it's not a panacea, but that's what really we refer to the tumor staging, and we use the primary tumor, the lymph nodes, and then we also look for any distant, perhaps, involvement. The question regarding differentiation of a tumor is a vital one for the neuroendocrine tumor specialist looking after the patients. It's one of the first questions we ask. What it refers to is what the tumor looks like down the microscope. Most neuroendocrine tumors, whether they come from the small bowel, for example, or they come from the pancreas or the stomach or the colon, they look pretty similar. They've got patterns under the microscope that the pathologist will tell us that looks a little bit like what we call a neuroendocrine type profile. You get little cords of cells that are fairly regular with nuclei that are similar size, and when it's well differentiated, the tumors they've got a pattern that's very recognizable, and they're not aggressive. That the very important aspect when you're looking at the histology for neuroendocrine tumors is the size of the nucleus in comparison to the size of the cytoplasm. That the nucleus is sitting in the cytoplasm. As cells become more and more aggressive, tumor cells become more and more aggressive, the size of the nucleus increases in size, and the shape of the cells become a little bit more distorted. As the tumor dedifferentiates and becomes poorly differentiated, when you look down the microscope, you don't get that recognizable pattern of neuroendocrine cells that we see every day, and it can be very haphazard with lots and lots of we call pleomorphism, or cells that are indeterminate from one another, and they also have a very, very large nucleus ratio to the cytoplasm. So they lose the typical pattern of what we call well-differentiated tumors. And something that helps us enormously now, when we're not sure of whether the tumor is, it can be quite simple when it's very well, we call differentiated, it looks like a well-differentiated tumor, and then in the other spectrum you've got something that looks very haphazard and it's obviously very aggressive and we call poorly differentiated. In between then we've got tumors that have a little bit of a well-differentiated component and a slightly aggressive component, and we use then to help us tumor grading, and really that's just a tool using a little marker that we stain the slides with. It's called an MIB antibody, and this gives us what we call a Ki-67 score, and that's helpful. So that's called a grade. We use the grade to help us reinforce the notions of what the tumor looks like in terms of the differentiation. But it is important because well-differentiated tumors, they usually grow slower. Highly malignant, poorly differentiated tumors, they usually grow very fast, and the prognosis is completely different between both, as are the therapies. So the differentiation, combined with the tumor grade, really are important to tell us how a tumor is going to behave, and also what types of therapy we can use to address those treatment options.
If you've got a high-grade tumour, that is a grade 3 tumour, it does mean that the tumour is going to behave in a more aggressive manner. It means there's a much greater chance that the tumour will come back, and it will mean that you're likely to receive some form of additional or extra treatment. Usually this will be with chemotherapy. The type of chemotherapy will depend a little bit upon which part of the body the tumor has arisen. There is some confusion over the terminology that's used, and at present the World Health Organization and ENETS pathologists are having a sort of battle to try and decide which system is going to be used. But the term neuroendocrine carcinoma is increasingly being used when it's a grade 3 or G3 tumor. So this means it is at the more aggressive end of the spectrum, and therefore has or carries with it a more significant or worse prognosis and the requirement for extra treatments.
So I think that the unknown primaries are probably, there is a primary, we just haven't found it yet, for the most part. Whether there are really patients with either lymph nodes or liver disease that do exist without a real primary, in other words, can you have a primary neuroendocrine tumor of the liver? I don't know is the answer. I think it's less and less likely. It's my opinion.
One of the problems with neuroendocrine tumors is they can arise anywhere throughout the body. They start off as 1 or 2 cells, that's just tiny, something like a grain of salt. And very often the primary tumour never grows in size very much, but quite early on, or maybe quite late on, it spreads into the lymph. And then after that it goes to the liver. So there might be a lot of tumour in the liver, but this tiny tumour somewhere, and locating that can be difficult. So to have a test that gives a clue of where it might be is very good.